Okay, thank you. So now I want to turn it over to the formal part of the afternoon for you. Introduce Dr. Rayson again from this morning, our continuity into the afternoon, who will introduce his colleague, and it goes from there.
Thank you very much, Jim. So just a minute, I just want to introduce you to Dr. Jeff Porter, who's going to be chairing the afternoon session. Jeff is not only a very valuable colleague of mine, but also a friend, a surgical oncologist here in Halifax at the QE2 Health Sciences Centre, and the Ramia Chair of Surgical Oncology and Division of General Surgery. And Jeff has been involved with a lot of our multidisciplinary discussions regarding integrating systemic therapy and surgical therapy for a lot of our patients here in Nova Scotia and now increasingly throughout Atlantic Canada. So I'll just turn it over to Jeff. And
Thanks, and again, thanks for inviting me, and I really have enjoyed the day. I was hoping one of the questions this morning would be, why doesn't Danny shake anyone's hand? But my job is to keep everybody on time, and I'm sure we're going to have equally, if not better, talks and interaction afterwards today, so I really look forward to this afternoon. So our first presenter is Steve Burrell, and Steve is another member and an important member of our team in Halifax. It's nice how we've had three in a row. Nothing to do with the order, because if there was, Dr. Ali would be last. Steve is a radiologist and nuclear medicine physician and trained in Halifax. Did a fellowship at Harvard and has come back and has, again, really taken a leadership role at our institution with regards to treatment of neuroendocrine disease from a nuclear medicine perspective. So, Steve?
Okay. Thanks, Jeff. I'd like to thank Dr. Rayson and the organizing committee for inviting me to speak. I don't think I've been to such a well-organized conference before. I certainly know I've not been to such an enthusiastically organized conference before. It's a bit of a atypical audience for me to speak to. There are healthcare professionals, and there are patients and people with varied levels of knowledge, so I'm hoping that there's something in this talk for everybody. So basically I'm talking about imaging of neuroendocrine tumors. And this is it. There's really three parts to the talk. A little bit of an introduction about what we do in diagnostic imaging. You sort of have had a bit of a prelude to that from some of the presentations this morning. And then it really gets broken down into two parts: anatomic imaging, which is mainly CT and MRI, and nuclear medicine imaging, which occupied MIBG and PET scans. I'll probably talk a little more about nuclear medicine. That's my area, and there's a little more to be covered, I think, in the nuclear medicine. So just by way of a prelude, a brief overview of neuroendocrine tumors. I usually have this in my talks. After the morning, you hardly need this, but this is my simplistic view of the world of neuroendocrine tumors. We have our carcinoids, which can be in the lungs or in the gut, most frequently in the lower gut. We have our pancreatic neuroendocrine tumors, formerly known as islet cell tumors. Pheochromocytomas, which often arise in the adrenal gland. Medullary thyroid cancer, and we have Merkel cell tumor. And as you know, these various tumors are kind of unique in that they tend to secrete various peptides. So carcinoid tends to secrete serotonin. The pancreatic neuroendocrine tumors secrete a variety of different peptides. Pheochromocytomas emit catecholamines. Medullary thyroid cancer, calcitonin. And I don't know what the Merkel cell tumors emit. They're pretty rare. I was hoping I would learn today. But and then I can update my slide. But in children, we have an equivalent. We have the neuroblastoma, which also emits certain catecholamines. And just going back to real basics as we sort of move into talk about imaging here. So how do we assess any disease, whether it's cancer or specifically neuroendocrine tumors? And the way I think about it, we can sort of classify it into three categories. We have the clinical, where we talk to the patient or do a physical examination. We have the laboratory, where we have blood work or urine, other bodily fluids, tissue biopsies. And then we have the world of diagnostic imaging, which is what we're going to spend the next half hour discussing. One thing to keep in the back of your mind, it's not really critical to the talk, but what is the role of diagnostic imaging in cancer? What are the time points in which we'll image cancer? So we may do it at initial detection, either population screening. We obviously don't do that in neuroendocrine tumors. Mammography would be an example of that. Or we might do directed evaluation to diagnose cancer in somebody who we think we have a suspicion they may have it. Once it's diagnosed that the patient has a cancer, we need to stage it. We have to know how far and wide it has spread, so that's another time point for imaging. And we want to assess response to therapy. In some cancers, we actually assess with imaging mid-cycle. Many others, it's more at the end of therapy. And then we want to evaluate for recurrence later on, further down the road, either through some mechanism or some plan of routine surveillance or directed evaluation in someone in whom you think the cancer has recurred. So we'll just kind of keep that in the back of our minds as we go through the different aspects of imaging. Here we go. So this is sort of where it all began. William Röntgen in 1895 developed the X-ray. This is his lab here. And this is the first human X-ray. This is his wife's hand. And I think today when we develop new tools, maybe radiation emitting tools, we tend to test them out on animals or maybe medical students. But this was Röntgen's wife's hand. It's the first ever X-ray. And just to, again, put things in perspective, numbers from 2009, but here at the QE2 in Halifax, we do about 1,000 diagnostic imaging studies a day. You can see, if those of you who can see the bottom of the screen here, it's still dominated by X-ray. CT and mammogram are also X-ray modalities, so it just speaks to how even 116 years later, Röntgen's X-ray really still dominates the field. But we also have ultrasound, developed from wartime sonar applications, MRI, which we'll be seeing, and then nuclear medicine and PET, which are, although there's small numbers here, they're very important in the world of neuroendocrine tumor imaging. Where am I going? It isn't ergonomically friendly. So for the nets, this is what we're going to talk about. We're going to talk about the anatomic imaging, CT and MRI. As I alluded to, we're going to talk about nuclear medicine techniques, which actually assess a different concept, molecular processes. And we're not going to really talk about it, but occasionally patients will have an X-ray or an ultrasound. So let's start with the anatomic imaging and talk about CT scanning. Probably everyone in this room either has had a CT scan or is quite familiar with it. Basically, it's an X-ray based modality. The X-ray machine rotates around the patient very quickly, and by imaging from all directions, able to create a 3D data set, which we then display back in a series of slices through the body. Gives us exquisite anatomic detail. It's widely available, and it really is the workhorse of cancer imaging. This is a CT scan. You saw going through the abdomen. You saw an arrow flash by there. We'll see that still in a moment. Kidneys going out of view. This is all gut down here. The white part is because those of you who have had a scan may remember you drink a drink of contrast, which lights the gut up so we can distinguish the gut from other tissues. And this is the same patient just slightly later on a different phase of intravenous contrast. So in addition to the oral contrast, you may remember you get an injection typically of the intravenous contrast, which lights the organs up. And we'll just highlight the differences why we do these contrast agents. So here are three CT images in a patient with a pancreatic islet cell tumor. So this is the image pre-contrast. Bones are very dense, so they stand out very highly. Gas in the bowel is black, but you can see a lot of the other organs, they look very much, it's hard to distinguish one thing from the other. So we give the intravenous contrast, and here's what we call the arterial phase. This is very early on. And if you look right here is the aorta, and there it is there in front of the spine. And you can see how that has really lit up with the contrast. You can see the splenic artery coming back here. And so in this early phase arterial imaging, we see the vasculature lighting up. And then a minute or so later, we come back through a third time with the portal phase. And now if you look at the liver, for example, you can see all the vessels in the liver are lighting up differently. The spleen is lighting up differently. And really the contrast really helps tease out different organs. This arterial phase is actually usually not done in most cancers, but it is done in the setting of pancreatic islet cell tumors, for example, because they tend to light up on that early phase. And for those of you whose CT anatomy is a little rusty, this is the pancreas here, and this is the little islet cell tumor that was lighting up. So barely see it standing out from the background tissues on the pre-contrast, but you can see this little tumor here lighting up on the arterial phase, and then perhaps a little less so on the portal venous phase. Different patient, CT through the abdomen, liver, kidneys coming in back here, bits of bowel out here, big kidney cyst. And you saw an arrow flashing on something there. I'll let this run through again, down into the pelvis here. Heart, lung bases, this is the stomach. Liver going by, kidneys again. And you can see this lesion here. And this is it still. So this is a carcinoid tumor in on a CT scan, a very typical pattern. All of this black is intra-abdominal fat. The white is in the gut, but here's the tumor here. And out there, tumor here. And interesting aspect is you see all these little, looks like little tendrils almost coming off the tumor. That's really a reaction within the fat. It's called a desmoplastic reaction, and it's classic for carcinoid tumor. So that's CT. Again, it's really the workhorse in neuroendocrine tumor imaging, almost any tumor imaging. And before people tend to move on and have nuclear medicine, they've almost always had a CT scan at some point. MRI is the other anatomic imaging modality that gets used, not quite as frequently as CT. And rather than using X-rays, it's based on manipulating a big magnetic field around the patient to tease out properties of the molecules and create an image. The spatial resolution is not as good as CT, but it has great utility in distinguishing different tissues from one another. This is I think we have a video of it actually. So here's similar to what you just saw with the CT scan. This is an MRI being played, scrolling down through the abdomen. There's the liver, there's the spleen lighting up. You can see different vessels. Saw an arrow pop in there. We'll see that again in a minute. Here come the kidneys. See the arteries quite nicely coming off here. I'll let that run through one more time. This is the base of the heart here. Aorta is going down, liver, spleen, pancreas coming across here, gallbladder up here, kidneys lighting up. So here's a still from that MRI. Here's the pancreas, and here's that little islet cell tumor. And if that looks familiar, yeah, it's the same patient you saw the CT scan of a moment ago. So actually here, the anatomy doesn't look too bad as it's presented here. This is a contrast-enhanced T1 sequence, but there are other sequences where the images don't look quite as good, but we get really good information out of the study. For example, this study here, it's what we call a T2 sequence, and you can see the arrow flashing in, looking at this really bright object here. And that's a pheochromocytoma. This is a classic MRI appearance of a pheochromocytoma on these T2 sequences. The terminology is that they're light bulb bright, and it really leaps out at you there. So that's, as I say, a bit of an introduction to anatomic imaging, CT imaging, and MRI. Now we're going to move into nuclear medicine imaging, which you heard a bit about this morning. Really, there's three modalities I'm going to talk about, although there are a couple of unusual little cases slid in here as well. But for the most part, we're talking about occultized scans, MIBG scans, and to a lesser extent, I'll address PET. So just by way of background to who we are in nuclear medicine and what we do, It's different from anatomic imaging in that we're injecting a tracer, which we call a radiopharmaceutical. The radiopharmaceutical basically possesses two general properties. First of all, it has some physiologic property that we want to exploit, such as being incorporated into cancer cells. And the other thing is that it contains a radioactive tag, which emits energy and allows us to create our images which show the distribution of the radiopharmaceutical throughout the body. And we consider ourselves assessing molecular processes rather than anatomy. So let's start with the octreotide scan. You heard a lot about octreotide this morning. You heard a lot about somatostatin for that matter. And the point was made that the half-life is very short, 1 to 3 minutes. And so the 8 amino acid analog, octreotide, was developed. And just as you heard about that in the setting of therapy this morning, this is what we use in imaging. We basically bind it with a radioactive isotope, indium-111, to form the actual agent that we inject. This was mentioned this morning. It binds mainly to the somatostatin receptors type 2 and 5, and it has a high sensitivity for most neuroendocrine tumors. And the reason is that, again, I think as was discussed this morning, many neuroendocrine tissues, even normal tissues, have high amounts of somatostatin receptors. And when a tumor develops from neuroendocrine tissue, it even further overexpresses somatostatin receptors. So they're very highly expressed on many neuroendocrine tumors, and that's what we utilize for imaging and perhaps increasingly in the future, as was discussed, for therapy. Octreotide scanning, it's used in neuroendocrine tumors, again, at a variety of time points. This is a little bit similar to what I alluded to generally at the beginning of the talk, so I think I'll just jump over that. So here's an example of a normal octreotide scan. As with most of our studies in nuclear medicine, it doesn't have the fine spatial resolution that you saw earlier with the CT and the MRI, but again, we're assessing physiology and function. So that was a normal scan. We'll just take a look at a few abnormal scans. Windowing, probably not all that great. We have normal uptake in the kidneys and in the liver and in the spleen, but there are a couple of abnormalities here. You can see this focus down low in the abdomen. This image that you're looking at here is a slice through the scan. It's called a SPECT image. It's really the nuclear medicine equivalent of a CT. So it's a three-dimensional scan that's being displayed in a series of slices. And here's the corresponding CT on that patient, and this is the abnormality here, and it looks similar to the one we saw earlier. You can see this desmoplastic reaction in the mesentery, these little tendrils sticking out, if you will. So this is a classic carcinoid, and again, it's hard to appreciate from this image, I realize, but when we go up into our slice up higher and put it against the CT, this is normal uptake in the kidneys back here. Here are the kidneys. Here's the liver, but here's this very, very large carcinoid metastasis in the liver, and you can see the uptake within it on the octreotide scan. There's no uptake centrally, and it looks quite different anatomically centrally because it's necrosed centrally. It's probably outstripped its blood supply. Carcinoid syndrome was talked about this morning, and I know it's a big issue, of course, and I won't dwell on the clinical presentation, other than to tie in a couple of perhaps interesting points which we can demonstrate with imaging. So much of the carcinoid syndrome, of course, comes from the serotonin that's released, tends to get metabolized in the liver and lungs and excreted out in the urine. So it's said that for a gastrointestinal carcinoid, and most of them do arise in the gastrointestinal tract, to produce the carcinoid system, there must be liver metastases. And here's the reason for that. Here's that scan we saw earlier. There was the carcinoid down here. Carcinoids in the gut, as with the rest of the gut, their blood supply drains through the portal system and goes to the liver, and the serotonin gets broken down, so it can't circulate systemically and cause the carcinoid syndrome. It's blocked. But if they have metastases in the liver, like that big metastasis we saw, the blood flowing out of that bypasses the liver, gets dumped into the hepatic veins, and is able to circulate systemically. This is a study we do a lot in nuclear medicine. It's a myocardial perfusion study, and you might wonder why that's in here. We do these for people with coronary disease, with heart disease, and this is just one that came by one day. And we noticed that these are images of the left ventricle. We noticed that the right ventricle looked larger than typically seen, and perfusion was normal. That's sort of an incidental finding. And when we dug a little deeper, we found this person had an echo, and the echo had shown that the right ventricle was indeed enlarged, that the tricuspid valves were fixed, they weren't moving, that there was really severe tricuspid regurgitation through the tricuspid valve, and these other issues which are sometimes seen in this particular entity weren't really present to any significant degree. So it turned out this was a patient with carcinoid heart, which was alluded to a couple of times this morning, and these are the classic findings that they get. I don't know if this number really, I found this in this one reference, whether it really occurs in greater than 50% of those with the carcinoid syndrome, but it certainly is common. Predominantly occurs in the right side of the heart. Virtually all of them get this tricuspid regurgitation, where the valve is thickened and retracted, and they get these other also right heart issues. So you may say, why the right heart? The presumed explanation is that it's a desmoplastic reaction to the serotonin. So just as we saw the carcinoid putting out the serotonin in the gut and having it broken down in the liver, same thing can happen when it's traveling systemically, goes into the heart, it affects the right side of the heart, but then when it goes into the lungs, it also gets deactivated there. So it's not because of direct metastases of carcinoid tumor to the heart, it's because of the serotonin. Yeah. And this is the real imaging way to look at carcinoid heart. This is ultrasound cardiac echo. Just to orient you, this is the left ventricle over here. This is the right ventricle here. This is the one we're interested in. Right atrium's up here. This is the tricuspid valve between the right atrium and the right ventricle. And I know you've not seen a lot of these, but I can tell you it's not opening properly, fully, and also it's not closing fully, which is going to allow blood to travel backwards. One thing we do with ultrasound, we have a technique called Doppler, which basically, when you turn it on, it assesses blood flow. It displays it in a color format. So here's the blood flow, and even if you're not completely following this, I think you can appreciate that it's going in both directions. It should only go in the one direction. So this is a person whose tricuspid valve is not working because they have carcinoid heart. A few other octreotide scans in the setting of neuroendocrine tumors. Probably run through these a little quickly. Frontal and posterior views. We should have normal, some liver uptake, some spleen, and some kidneys, but here you can see the liver is really heterogeneous. There's probably some uptake in the chest up here, which are metastases, and there's a big tumor sitting centrally here as well. You can see it nicely on CT. It's a patient with a gastronoma. Another gastronoma case. Patient had all the classic symptoms, but we really know they have a gastronoma because their blood gastrin levels were significantly elevated. But they couldn't find the gastronoma. The patient had all the standard imaging, standard workup. So the question is, where is this gastronoma? So they had an octreotide scan. Here are the frontal and posterior views. There's just one abnormality here, and it's this little focus down in the gut here, not actually in the bowel, but in the abdomen, I should say. And you can see how it's standing out so strongly from the other organs. So this was the gastronoma. I'm going to show you in a second the slice through it called a SPECT. And one thing we're doing now in nuclear medicine is we have hybrid imaging where the nuclear medicine camera, whether it's a PET camera or a SPECT camera, is amalgamated with a CT scanner, as Dr. Turcott showed this morning. So that was the case with this study. So this was done on a hybrid SPECT CT scan. So the top image is the slice through here from this actual study. Remember, we have normal kidneys, normal liver, so here's the little gastronoma here. Hard to see where it is on the CT scan, and then you can see the fused data down here, and you can see in color the SPECT abnormality superimposed on the CT. And it's just this tiny little nodule here. So really, it points to the ability of nuclear medicine to use the high tumor to background ratio, if you will, to find tumors. And patient with an insulinoma, very enlarged liver, very heterogeneous. Here's the slice through that SPECT scan. Here's the corresponding CT scan. You can see some of the tumors are cold. They're not octreotide avid. Probably necrosed. They're probably dead, but several of the others are. So that's an overview of octreotide imaging. MIBG imaging is the other classic scan that we do in nuclear medicine for neuroendocrine tumors. MIBG is meta-iodobenzoguanidine. I have a few slides in here that talk about what that is. I think in the interest of time, I'll kind of skip through these. I think the thing to know is that it's basically similar to norepinephrine or noradrenaline. And so it gets taken up in cells of neural crest origin, and particularly tumors that are derived from those. The uptake is via this active uptake 1 mechanism. And again, I think this is probably more detail than we want to get into. The question that arises is, when do you do MIBG scanning or when do you do octreotide scanning? This is the octreotide recall. And it doesn't hold in everybody, but the general, in most people this will hold, that MIBG is better for pheochromocytomas and neuroblastomas, whereas octreotide is better for all the other agents, or sorry, all of the other neuroendocrine tumors. But it doesn't always hold in every patient, and it may be that in any given patient, the tumor doesn't follow the book, so to speak, and when you think they should be hot on octreotide, they're more avid on MIBG or vice versa. And this is an example of that. This is the same patient, and you can see this is an octreotide scan, and this is the MIBG scan. And again, it's a patient with a carcinoid, so we may anticipate that the octreotide scan is going to show more disease than the MIBG scan, and that is indeed the case. The MIBG scan, I can tell you this is all normal uptake, but here you can see the tumors with metastases and liver lesions on the octreotide scan. And this has implications for therapy. I'm not going to get into therapy in this talk, but we can treat people with MIBG avid tumors with very high doses of MIBG, and this basically tells us that this particular patient, for example, would not be a candidate for that therapy. It also speaks to the interest in the newer agents, which are like lutetium that was discussed this morning, which are bound to somatostatin analogs. Patient preparation, those of you who have gone through this scan are familiar with this. We want you well hydrated, but mostly there's a very long list of potential medications that can interfere, so if it's safe, we have you come off these medications. And because this agent is labeled with radioactive iodine, a little bit of iodine may come free, go into your thyroid, and potentially do some thyroid damage, so we give you some Lugol solution to block the thyroid uptake. Quickly, this is again more than you really want to know. I think there are two flavors of MIBG. There's two different radioactive isotopes we can label it with, iodine-123 and iodine-131. And the quick take-home message is that iodine-123 is a better imaging agent. This is an example. Same patient, two different time points. This was before we started using the I-123 here in Halifax, probably about 10 years ago. And here's the what we've been getting for the past decade with the better isotope labeled to the MIBG. A couple of quick examples here. This is a patient with an MIBG, had all the classic biochemical and clinical findings of a pheochromocytoma. Frontal and posterior views, again, I know you're not familiar with what should be normal and what isn't, but basically on the posterior you see this really bright focus here. When we go to the slice through it, it's here. And this is the patient's MRI, and there's that light bulb bright pheochromocytoma. Nicely demonstrate with these scans that there are no distal metastases. Another patient with actually two pheos, one on each side. Here's a CT here. You can see the uptake here corresponds with this mass. That's just the kidney. And then this larger one, similar to that liver lesion we saw a while ago, where the central part is not the least bit active. It's just dead. So a patient with bilateral pheochromocytomas. Same patient, you saw some of this from Dr. Imran's lecture before lunch. This same patient also had elevated calcium, parathyroid hormone, and calcitonin, and underwent a different form of nuclear medicine study, one that we don't do all that commonly. It's a session3 scan. We do it commonly for cardiac imaging, but for this particular application, it's kind of infrequent. You can see all this activity in the neck. This is in the thyroid mostly, but then we do some delayed views and the thyroid is washed out and you see this residual nodule here that's taking up the MIBG. And then when we went back and looked on the CT, different planes of imaging there, you can see the nodule that's responsible for it. And this is a parathyroid adenoma. This is a tumor that secretes the calcitonin. So the diagnosis was that this patient had an MEN syndrome. I won't dwell on this. We saw this from Dr. Imran's talk. But remember, this patient had pheochromocytoma, actually had two of them, had a parathyroid tumor, and has a 99% likelihood of getting a medullary thyroid cancer. Finally, in MIBG neuroblastoma, we do these studies. These are in children. And again, along with the PHEOs, neuroblastomas are the other main indication for doing MIBG. This is a patient being staged for neuroblastoma. You can see multiple lesions throughout the body, which represent metastases. And again, the nuclear medicine imaging is excellent at finding the lesions, but also very excellent for following them post-therapy. This has completely resolved. There's no tumors left post-therapy. Finally, a multimodality case, just to maybe pull it together a bit. Image from a CT scan, kidney here, just the top of it, but you can see there's a sort of non-specific tumor arising from the region of the adrenal gland. Patient gets an MRI. You might think that's the kidney, because that's the left kidney, but this is actually all the tumor. There's some areas in it that are very bright, the so-called light bulb bright pheochromocytoma, and this is the patient's MIBG scan. You probably don't need the arrow to see the tumor. So it basically confirms that this is a pheo and nicely tells us that there are no metastases anywhere. And I just put this in this morning. My only reference to therapy, this was an imaging talk, but just following up on the discussions, we are getting into the world of iodine-131 MIBG therapy. We've done approximately 10 of them in the past 3 years, and importantly, it's really increasing in frequency. We haven't done one for a while. Kathy, what's it, 18 hours now? 19 hours since our last one? Yeah. Okay. Final aspect of nuclear medicine is PET, and I'm just going to go through this very quickly because Dr. Turcotte spoke to this morning. In fact, I have a lot of discussion in here about how it differs from other nuclear medicine. I don't think we really need to go there. Having said that, I'll briefly go there. Basically, the thing that makes PET different than other nuclear medicine is that the isotope decay is different. It's through positron emission and requires a different type of camera. But practically speaking, the difference is that we have different tracers, different pharmaceuticals that we can image with PET. Really, PET has revolutionized the imaging of many cancers, as I think many of you know, so not so dramatically for the neuroendocrine tumors. It's a patient with a lymphoma, PET very elegantly demonstrating the intense widespread uptake in the patient with lymphoma. As we mentioned, they come fused now with the CT done simultaneously or near simultaneously with the patient not moving. And you can see the PET data in color superimposed on the CT. Whether PET is useful or not in a particular tumor really comes down to the tracer. And again, this was previewed a bit this morning. Here in Halifax and throughout most of North America, most centers only have access to this one tracer. FDG is a sugar analog. And the problem with the neuroendocrine tumors is that most of them have relatively low metabolic rates. This was alluded to this morning, that most of them are, fortunately, well-differentiated, well-behaved tumors. They tend to take up the somatostatin analogs. They tend to take up the MIBG, but they don't have high metabolic rates, so they tend not to take up FDG. However, as was again mentioned this morning, some are not well differentiated, so it's not uncommon to, or kind of what this leads to is that Most neuroendocrine tumors will be better imaged with the traditional imaging, but those that aren't positive on traditional imaging, now there's a good chance they will be hot on PET. Just one sample case, medullary thyroid cancer. Here's the lesion here, and it is lighting up nicely on PET, and this is the whole body PET scan showing, unfortunately, widespread disease. What's next, and Dr. Turcotte spoke to this, so what's next is, can we get some PET agents that are more specific, or more likely to be taken up in neuroendocrine tumors, and he talked about the gallium-68 labeled somatostatin analog that they're developing. These are just some images from Piet Jager from the Netherlands of a different type of tracer called F-DOPA, patient with carcinoid, patient with a paraganglioma. Patient with a standard FDG PET scan not really showing any tumor, this is mostly normal uptake, but then with the F-DOPA PET showing all sorts of tumors. So it speaks to the fact that with these newer potential PET tracers, we may find a wider role for PET in neuroendocrine tumors. So finally, we talked about 3 different types of nuclear medicine imaging, and everybody's left wondering what to use for what tumor, and this came out of the questions. So let's go back and visit our tumors. So carcinoid, the first test, octreotide is the best. For the pancreatic neuroendocrine tumors, octreotide is the best. For the pheochromocytoma, that's the MIBG. For the medullary thyroid cancer, these guys actually are fairly hot on PET, FDG PET, so I think that would be my recommendation as a first-line nuclear imaging modality. Merkel cell tumor of the skin, very rare, but they're also being well evaluated with PET. And finally, in children, the neuroblastoma, MIBG is still our imaging agent of choice. So just in summary then, diagnostic imaging, as you knew before you came, and as we've seen, allows us to look inside the living body, essentially assess anatomy and disease processes. The first-line imaging modality is usually CT. Gives us an excellent assessment of human anatomy. It's widely available. Increasingly, MRI is being used for the pancreatic neuroendocrine tumors and for pheochromocytomas. And regardless of which anatomic imaging route is taken, there's an important role for nuclear medicine, because increased uptake of radiopharmaceuticals in these tumors provides high tumor to background ratio or levels, so we're able to tease out and find tumors that may have been hidden by all the normal anatomy on CT and MRI, and allows us to better assess whether the tumor has been adequately treated post-therapy. But ultimately, I think in most neuroendocrine tumors, some form of anatomic imaging and some form of nuclear medicine, they're complementary and are usually needed. And that's it. So, thank you.